I am deeply worried that the general practice is going to go towards the dental model. First five young GPs don't want to be partners. I don't think it's true. You don't just walk into a partnership if you're a GP considering it. Partnership is just like being in a marriage because you're going to enter into an agreement with a group of other people.
Welcome to Dr. Erwin Kwun's show, where we bring you real stories to inspire you and help you lead a fulfilling life. Today's guest is Dr. Selva, a GP who is driving meaningful change within the system. Dr. Selva has crafted an impactful career. You've had such a diverse career: GP partner, educator, advocate, and also on the board council of the RCGP and BMA. Hi, Dr. Selva.
Hi, Erwin. Absolutely. Thank you for having me, first of all. It's great to be sharing my journey. So I am originally from Sri Lanka, so that's where I was born and brought up, and I came to the UK as a teenager, not being able to speak English properly. I could construct some sentences, but other than that, it was a challenge. And then I grew up in East London. Went to a comprehensive school in East London, and then I went to medical school at Royal Free. So I've never wanted to be a GP. That was so when I was in medical school, GP was not something that attracted me. I thought GPs were it wasn't an exciting career. I didn't have um, the best opinion of general practice. And then so I decided I'm going to go off on a career as a hospital doctor. Acute medicine at the time, this was early 2000s, was looking really exciting. It was an early specialty. You see the sick people, and then you fix them, and then they go back home. And it looked very exciting, much more exciting than A&E was. And then I knew I never wanted to be a surgeon. Um, and then I embarked on a medical rotation. So my registrar at the time, he was saying, Silva, why are you spending so long with the patient? You're finishing the ward rounds at least 2 or 3 hours late every day. Why are you doing that? You're just sitting there talking to them. You're trying to find out what made them ill. You're trying to find out why did they come to the hospital? Who's at home with them? Um, why are you so interested in their personal lives? We're doctors. We fix problems. We send them back. Uh, and then I kind of thought about it, and then he said, "Have you ever thought about being a GP?" It wasn't as a compliment. It was as a, you know, maybe you should think about something else. And that's when a light bulb went in my head. And so, in 2007, spring, I resigned my medical rotation, applied for GP training, and never looked back. And it was the best advice that was given to me. So what I would say to everyone is, even if someone says something negative to you, uh, take it on board because we can always learn the lessons, but from both positive and uh, negative feedbacks. Um, and that was the best decision I made because I want to facilitate people's health. I want to address health inequalities, and I want to be a whole person expert. I don't want to be a doctor who just specializes in one area of medicine, and also be part of a community, be a continuous character in as people go through their lives. And it's a privilege to be a GP. So, best advice, and I've never looked back since then.
That's amazing. So, to somebody who is thinking about wanting to go into a GP career, what advice would you tell them? Because GP might not be the career for everyone, though.
Absolutely, absolutely. So, the last I heard, there are apparently 200 specialties and subspecialties in medicine. So that's the great thing about being a doctor is you can choose a specialty that suits you, suits the kind of person you are. We're all very different. I think a GP needs to be interested in people. Uh, they need to be really good at communication skills. So my tongue needs to be as sharp as a surgeon's scalpel, and I need to be a whole person expert and be able to be prepared for more slow burn. So it's about continuous care, making sure somebody's got diabetes. I keep them as healthy as possible for the longest possible time, and looking at how do I prevent from someone from getting ill. Of course, we do some transactional things, and I think it's a career that also embraces innovation. So a lot of the innovations that have taken place in general practice have taken place in GP. So we were the first to use computers in the NHS. So electronic patient record systems came into GP in the 90s. Hospitals have just, I think, gone fully digital, even though we still get lots of papers by hand. I haven't actually written anything by hand for years. We have electronic prescribing. We do total triage systems. A lot of us are using AI scribes, AI to file blood tests and documents. So it's a specialty that I think enables you to innovate. So enables you to practice your craft as a doctor, but also think about what else can I do? And I'm a GP partner, so this means I, along with 12 others, own and run 4 surgeries, and that really gives me a much wider exposure into more systemic thinking. You know, how do we shape our services to the needs of the population? Well, how do we safeguard our future? How do we balance the budget? How do we ensure sustainability, whether that's in terms of climate action or whether that's in healthcare? So it's a really fulfilling career that enables you to think about much wider things, along with being purely clinical medicine.
Yeah, so that's great. And it sounds like you've been able to shape a really good career where you enjoy what you're doing and you're making the changes. That means a lot. So tell me about what it takes to be a partner, because it is a lot of responsibility and people might not be aware of all the responsibilities. Talk about things that people might not understand, or somebody who's thinking about GP career and considering partnership.
Okay, that's a really great question, because the statistics show only about half of all GPs are now partners. It used to be a much higher percentage. Prior to 2004, pretty much all the GPs were, apart from some who chose locum and salaried, were partners, and that number has been dwindling. So partnership as an option is perceived to be not attractive. Um, but I'll counter that actually, and just give you some information. So we've just taken on 4 new partners in our partnership last year, and they were all our salary GPs, all first fives. So these are so the notion that first 5 young GPs don't want to be partners, I don't think it's true. I think it's just the right climate hasn't been created. So there's probably various factors. The partnership model has been talked down on as the reason why general practice is in crisis, or why NHS is in crisis. But if you look, general practice is the only part of the NHS that operates on a zero deficit model. If you're a GP partner, you have a contract. If you don't deliver the contract, you get it taken away, or you don't take enough money home and you hand back your contract. And the GP funding has been falling year by year by year. So what that meant is a lot of partners are earning the same as they did 20 years ago. So the funding has gone, expenses have gone up. So it's become really challenging, and the government hasn't really, successive governments haven't really supported the partnership model. Even though, in my opinion, that's probably what's holding the NHS and general practice on collapsing, because these are people with skin in the game who will do whatever it takes to make sure their organization can sustain itself. But that's not to say it doesn't come without challenges. So you quickly need to develop some expertise in how to manage finances, how to look at budgets. You don't need to be an accounting expert, but you just need to have a good eye for looking at numbers and broader figures. You need to know about clinical governance. You know, what are the information governance issues we need to be aware of? GDPR. There's a CQC preparations, and then recruitment, human resources. But if you have the right managers, if you have the right set of partners, it's absolutely the best thing to be. And I'm blessed to be where I am in Bromley Health with the great partners and great senior management team who kind of lets us get on with what we need to do. So I think it's really important you don't just walk into a partnership if you're a GP considering it. So you got to partnership is just like being in a marriage, because you're going to enter into an agreement with a group of other people to abide by certain conditions, and you're financially tied. Your home is at risk if you don't run your organization sustainably. So there are those risks, but there are also huge rewards as well, in that you have a lot of autonomy compared to other medical specialties to shape how your services are delivered. You don't need to run 10-minute appointments. So we moved to 12 minutes to 15-minute appointments, depending on the type of clinicians we have. And we moved to an hour-based system rather than a session-based system. So um, we've got this outdated session-based system. A session is supposed to be 4 hours and 10 minutes, but in reality, it can be about 7 hours. So you could be spending 12 to 14 hours a day, and you've just been paid for 2 sessions. So for all of our GPs, including partners, we moved to an hour-based system. So I do 2 12-hour days, 6 sessions. So everything we do is defined. So it gives you more autonomy to shape your surgery. Now, funding is always going to be an issue, but that's where I think if you're a bit entrepreneurial, if you're treated like a business rather than an NHS organization, you can look at bringing in additional revenue streams and partnering with other like-minded people, neighboring surgeries, and various other things to deliver enhanced services. So I'm not saying it's all rosy. It's loads and loads of challenges. It's not an easy job to do. But if you're somebody who has a change mindset, if you're somebody who is willing to grow and expand, then I think it's the best job in general practice.
In that job as a GP partner, when you see that the funding is going down, as a business person, you might think there's not a lot of good opportunities in that business model. And then you mentioned about getting another sources of income. Now, when we think about the dental NHS, how it went, where patients are not really benefiting from such a long waiting list, funding is dwindling, and there are issues. So do you see that there could be problem in the future with NHS GPs?
Absolutely. So I've actually shared this on social media previously. I am deeply worried that the general practice is going to go towards the dental model. So the dental model doesn't work for the dentist. So we're not retaining the dentists in the NHS. So a lot of them are going private because of what the dental contract pays doesn't sustain their surgeries. So they're having to either offer part private, part NHS, or they're going purely private. So and young dentists are actually going into private practice much early on, even regardless of how many years of experience they have within dentistry. And I think that's to go into independent practice without the necessary experience and the kind of the full competencies, that can be challenging. Plus, for patients, it's not working. So where I work in Tower Hamlets in East London, not a single NHS dentist is taking on patients. And I'm having to signpost patients either 111 or to services outside of the borough. So there's a deep worry if we don't reform the GP contract, it's going to go the way of dentistry. And that's going to be more expensive for the taxpayer. It's going to be more expensive for the system because it's going to add to the waiting list. What you got to remember is general practice deals with 1.4 million patients a day. Far and above any other parts of the NHS. So even if you send 10% of those patients to the hospital, that's going to overwhelm the hospital waiting list. That's going to overwhelm the outpatient appointments, A&E departments, and so on. So it's within the absolute gift and priority of the government to actually make sure the NHS general practice doesn't collapse. The 25-26 contract is welcome. There is an uplift to it, although a lot of it's going to be swallowed up by the national insurance and wage increases. But I think we need a different type of contract, and this is a new type of contract that addresses all the fundamental challenges in general practice, and one that maintains the partnership model. But this is crucial. Recognizes that 50% of us aren't partners, 50% of us are salaried GPs or locums, and making sure we offer that flexibility. You were asking me earlier about the attractiveness of being a GP. I think the attractiveness of being a GP is being able to switch roles. So I'd been a locum GP, I'd been a salary GP, and I'm a partner. And I might decide sometime in the future. I've got no immediate plans to, but I want to take a step back, spend more time with family. So I want that flexibility. So and that's what attracted a lot of us as well. So we need to make sure that general practice is supported for GPs at all stages, but also in different roles as well.
You've been actually working to help in terms of the workload pressure, and your role in BMA as well. So if you had the power to make a one radical change, um, even within the NHS, what would it be and why?
Absolutely. So I say this to anyone who would listen to me. So we need to think about and so radical change. We need to shift the way NHS is funded. So at the moment, general practice is about 6% of the NHS funding, and we spend about 3% on prevention. Majority of the NHS spend is on reactive healthcare. So we're spending a lot of money in treating people who are sick. We're not spending enough money in keeping people from becoming sick or from keeping people in good health for longer. We've got lots of medicines to keep people living for longer, but not enough medicines or interventions to keep people from becoming ill. So in our partnership, we have the first ever what's called the population health contract, which is awarded by ICB for a period of 15 years, where along with delivering our core GP contract of being open 8 to 6:30 and managing their hypertension, diabetes, we are actually tasked with working with the local authority, with the housing association, with the schools, with the council, with the ICB, with the NHS trust in improving the health of the population. So, and that's called population health. So looking at your local population, what are their needs, um, and how do we address the inequality that they face? So I think we need to focus on population health. We need to focus more on prevention. So we need to shift the NHS from a sickness service to a wellness service. Because at the moment it's purely a sickness service. So you get sick, you use the NHS. We need to kind of flip that model, and someone told me 44 pence of every £1 of government spending is now going on health and social care, and that's only going to go up. We've got GLP-1s, which is going to be offered to everyone who's eligible. That's going to be about half the adult population. And how's that cost going to be met? Could we invest that better in preventing obesity, in exercise programs, starting nutrition and education classes from primary school onwards? And improving environments which promote obesity. So I think short answer is population health prevention.
Yeah. So prevention is definitely better than cure, and a lot of effort has been done by social prescribing and how to get patients to be thinking about that long-term health. I want to shift gear here. So let's talk about GP training. I've seen recently there has been many GPs struggling, like trainers struggling and trainees also struggling. What have your experience been?
So just to give you a background as to kind of why this is a big priority for me and also a passion. So I'm a GP educator, so I'm a GP trainer, but I'm also a TPD for IMG GP Trainees, and also the Guys and St Thomas's GP training scheme. And I have taken on international doctors who are GPs abroad and then want to integrate with the UK system. And I train non-medical professionals as well. There's huge challenges at the moment. So we have don't have enough jobs for GPs. So we're producing about 4,000 GPs every year, and they haven't got enough jobs to go to. And the practices don't have funding to actually offer them the jobs either. Yes, the ARS announcement that the government made is welcome, and it will make some impact. But the last year's ARS scheme only recruited from what I've been told, about 120 GPs. So it hasn't made the impact it does. I am hearing from GP registrars, ST3s, deeply worried about job opportunities afterwards. How am I going to find a job, and where am I going to find a job? So one of the things we've asked the colleges will be discussing this soon in the council is a mapping exercise to look at where the job availabilities and the shortages are. So at least we have, because at the moment we don't have the data about job shortages. Really important to get that, and then lobby the government to actually invest more into general practice jobs, GP jobs. The second thing is something I've been involved in. So in the BMA, as you would have known, junior doctors, as they're now called resident doctors, they went on strike, and then got some of the pay restored, but not all of the pay restored. And what's happened is consultants have got a deal, which is increase their salaries, but salary GPs, partners, and locums haven't got the same kind of deal. So an ST3 in London, for instance, isn't going to earn much more when they become a salary GP. So ST3 in London, a 40-hour contract, isn't going to earn much more when they do a 7-session GP job. So that's a major challenge. So I'm seeing trainees actually delaying taking exams or going 80%, 70%, so they can actually extend the training and then pursue other opportunities to ensure that they'll have a job afterwards, so portfolio career, but also they know that they're not going to earn as much. So this is the other thing we need to address. So there's jobs, but also well-paid job that recognizes the hard training that they've done. So I think these are the kind of two major issues. There is a need to evolve GP training, I would say. GP training, even though it's short, I think the reason it's short is you can't cover everything you need to cover in general practice, because it's such a vast specialty. Patient can come and see you about everything. You can train for 10 years as a GP, you still wouldn't cover everything that you need to know as a GP. So you've got to stop the training somewhere once you've reached the basic competencies. But with all the expansion of hours roles, multidisciplinary teams, as a GP, you're expected to lead them, you're expected to supervise them, you're expected to give guidance to them. And if you're on a consultant track, when you qualify, you're fully trained how to supervise the F2s, the ST1s, ST2s to ST, whatever the level they need to be. We don't actually have that with newly qualified GPs. So I think we need to kind of shift the gear in terms of helping them understand supervision and kind of train them on supervision skills, and also how a practice runs, management skills, leadership skills, to prepare them for the life afterwards. So those are the kind of three topics I would say. First is making sure there are jobs. Second thing is the jobs are appropriately paid, and then evolving GP trainees to the needs of what the workforce needs.
Have you found the insights in this video useful so far? If so, you might be interested in SEA Blueprint. Just click the link down the description below and sign up, and you will get a teaching from me every day for the next 7 days. These are really challenging things to address, and as we're seeing this problem carrying out, people are worried about the visa, and then other people are looking at other places where they feel like the grass is greener. So in terms of the next 5 years for general practice, do you see some exciting things coming that might help in these domains?
So about 56% of all GP trainees, so the current ST2s, from the data I have, are IMGs, International Medical Graduates. So if you look at who applies for GP training, 27% of the application comes from UK graduates, the rest is from IMGs. So general practice is a hugely popular specialty for IMGs. It's also the only specialty that doesn't have clinical fellows, trust grade doctors, SAS doctors. So you have an opportunity once you enter general practice training to become a GP. You're not stuck in a non-service in a service grade job for the rest of your career. So I think there are huge opportunities and advantages in becoming a GP for an IMG. But the job situation I was telling you about affects the IMGs a lot more than the UK graduates, because they come on a very short visa. So I know lots of trainees who are desperate for jobs, and they've only got 4-month extension. So if they don't find a job, they're going to have to go back, or they take up a job that they don't want to just so that they can get the visa. And so, I know of IMGs. I'm having chats through the ST2s that they're already planning to leave because they know UK isn't going to offer them the opportunity that they want. So, what we also know, we've got 30% fewer doctors than comparable OECD countries. So we're in a situation where we haven't got enough doctors. We've got doctors looking for jobs, and we haven't got funding to recruit those doctors. It's a complete mess. So I think unless the government recognizes this and offers a different type of GP contract that can ensure that we can recruit these doctors and retain them. That the money that they've spent personally, coming to the country, taking the exams, and going through all the struggles. It's not easy moving from one country to another. It's a lot of challenges, and they face lots of hurdles, including racism and other forms of discrimination. So done all this, and then it'd be really great shame to lose them because we haven't got the jobs and the visa facilities. So I would say probably one thing government can immediately make is, as in as a IMG enters GP training program, they get ILR, indefinite leave to remain, not a 5-year visa or because they're committed themselves to the NHS. So give them the ILR and then make sure there are enough jobs for everybody, UK graduates and the IMG. So I'm seeing what I'm seeing at the moment within the BMA and externally is there's a IMG versus UK graduate um, um, conflict being created because of the lack of training jobs and the opportunities afterwards. And there's enough for everybody. We just haven't got the training places and the funding afterwards for jobs.
Yeah.
So exciting things. Not in job opportunities unless things change drastically. But I think as general practice, there's lots of innovations happening. So tell you some really positive things that are happening in terms of if you're thinking about general practice as a career, but worried about jobs. So I hosted an AI hackathon last weekend, and it was entirely NHS led, general practice led. We had GPs, hospital doctors, and health tech developers all coming together and developing real world solutions to patients and medical needs at the moment. And it was so exciting to see so many who are balancing clinical medicine, so being a GP and health tech. I'm also meeting GPs who have gone into lifestyle medicine. I'm meeting GPs who've gone into things like medical legal work or consultancy. So I wouldn't despair. This is what I was kind of I would take it as an opportunity. Say, okay, yes, the NHS job situation is tough at the moment, but there are opportunities out there if you're willing to expand your mind and look at opportunities and connect and be curious.
Absolutely. And for me, developing a portfolio career has been really enriching and helpful to learn more and make new connections. And I can see in your career as well, it has developed yourself. So how would somebody go about developing a portfolio career?
Okay, that's a really good question. So I actually started in ST3 as an ST3. So but you can start at any time. So it's entirely up to you. So, I think one of the first things to do is connect with people. Find a mentor. So somebody who's happy to give you mentorship. So RCGP, and all trainees will be RCGP members. So on their website, they have a mentorship section. So do have a look and link up with a mentor. Your local schemes might also offer mentorship programs. So if you're an SD1, speak to an SD3, speak to your TPD. They will have the connection. Ask, is there a chance? So the AI hackathon I was mentioning about, I said to my ST3s and SDs at guys in St. Thomas, I'm holding this. Does anyone want to come and help me? I can't pay you, but what I can promise you is great connections on the day. And 8 of them signed up. So 8 GP trainees from ST1 to ST3 came, helped organize the day with me, but they also got involved with lots of tech products, spoke to a lot of AI developers and various other people. They made those connections, and now they've got further connections that they will take on to develop if they want to. And so I was a speaker in Next Generation GP leadership event a couple of weeks ago. That's a great one for the GP registrars to sign up to. Podcasts like yours, where you bring in different people who've done different things. And so I would absolutely would recommend finding a mentor and connecting, whether that's through your local medical committee, whether that's through your GP training scheme, TPDs, just emailing people. So I get emails from trainees I've never met. They say, Dr. Selva, I heard you speak, or I've someone told me about you. Can I have 10 minutes of your time? And I'm more than happy to give that up. And I speak to them, and a lot of them are absolutely grateful for that time, and they've gone on to do amazing things. So one of my ex-trainees has now moved to North Carolina and working for a health tech company. And prior to that, she was a clinical director for a large health tech company here. So it's about making that connection. And so look at the opportunities. Jobs will come up, and for example, within ICB, whether that's clinical lead roles or within the PCN, there might be supervision roles or supervising the arts roles like physios and pharmacists, for instance, or we recently advertised for a mental health lead, and that would have been ideal for a new GP. So you become the mental health lead. That means you're going to work with the consultant psychiatrist for the locality. You're going to work with the mental health nurses and the ICB team, and you're making that connection. And then once you're in there, then you'll see more opportunities open up. There's the faculties of medical leadership. Have a look at that. There are fellowship. Even though the national fellowship has gone, there are still some fellowships like the AI fellowship is available. There's a population health fellowship that's available for GP trainees in London. Always one of the questions I learned to ask early on is there a chance? Right? That's with anything. Is there a chance you could tell me about this? Is there a chance I can get a discount on it? Is there a chance that I could have 10 minutes of your time? And the worst thing someone's going to say is no, right? And don't be afraid to jump in, but jump in with, do your research, do your homework. So as I mentor a young GP, and she said, Selva, I need to speak to you about this role I'm thinking about applying for. It's a safeguarding role. I know a little about safeguarding. I've done some safeguarding in the practice, but this is a borough-wide role, and a lot of senior people have done it before. I'm not sure I should go for it. I said, look, let's break this down. You know about safeguarding. You've done other leads in your practice. You're supervising other people, and you're not going to be working on your own. You're going to have support around you. Just go for it. And she did. She's applied. She's got the job, and she's doing a really great job. So sometimes we might feel like we're not qualified enough. If you worked, one of the things I always tell my trainees and young doctors is, you've done lots of things right to get this far in your life. You know how to learn. You passed incredibly hard exams. You know how to communicate with human beings in distress. If you know how to communicate with human beings in distress, our patients, you know how to communicate with other people. So you're master communicators. You know how to work hard. You know how to work smart. So don't be afraid to go for roles.
I think it's very important to recognize the value that the skill sets a GP has. And sometimes GPs, they can discount themselves, or they think they don't have enough experience, or they need another qualification, because it's not just like the track of the medical training where you feel you need to have X, Y, or Z before you can do this.
Yeah.
I think giving them that confidence and showing them that they can do it, as you've done for your colleague, has helped them. And I think we need more leaders who are able to empower the next generation. And I think next generation GPs is doing an amazing job at that, because the leadership is going to shape the future of general practice.
Absolutely. And the other thing I would say is also RCGP faculties. So join the RCGP faculty. I'm in the Northeast London faculty, and they hold regular events. We held a AI event recently. It was all organised by first 5 GPs, and one of them is a rep to the RCGP, deputy rep for the RCGP Council. I'm going to catch up with him soon because he's thinking about becoming a partner. So it's really refreshing to see, and you get to make lots of connections with other GP colleagues in your area. So there are 32 faculties in the UK, and then so join the faculty is free for you. and they have dinners, they have events where they invite guest speakers, and it's a really great way of actually connecting with people. The point you made earlier, what I call diplomatosis, which is basically doing lots of diplomas and additional qualifications because you think it's going to make you employable. I have mixed feelings about it. So, if you're thinking you want to be a dermatology GP with special interest, pursuing a private career, absolutely, you should go for it because you need to have those qualifications. Um, if you think you're going to be a dermatology GP with special interest in the NHS, unless your local area, the NHS funds GPs to do minor surgeries and dermatology clinics, it's not going to be so attractive to the practice. What's the incentive for the practice to actually keep more patients out of hospitals if they're not getting paid for it? So spot the opportunity. So you can always go and say, look, I've done a joint injection course to the ICB. We could do this much cheaper in general practice, and it'd be quicker for the patients, more convenient for patients. We can cut the waiting list down. Can we do this for you? They might say yes, and so spot the opportunity and then do the courses that are appropriate to that. Don't just do courses without having a plan. Because I've seen some trainees, they come up with amazing qualifications, but then they're thinking about what they're going to do with it. It's that what Simon Sinek says. He's one of my favorite authors. Start with the why, right? Why do you want to do something? Yeah, don't just do things because you think it's a CV booster. Do things with purpose.
That's so important. Yeah. And in the NHS, you need to see whether there is a demand plus the demand is being funded. That's most important. If the demand is not funded, then won't be able to fulfill it. So tell us a little bit about how do you manage all these roles and doing things outside of medicine then?
I used to think you just have a work-life balance, right? Work is somehow 50% of my life, and then my personal life, my wife, kids, and the rest of my extended family. I've got a big family. It's the other 50%. So I somehow need to kind of give 50% to my work, 50% to the others. Then someone made me realize, as a mentor I have, your work is your life, right? This work-life balance is it's actually a false dichotomy. It's a false balance. So your work is part of your life, so you got to enjoy what you do. So when you get up in the morning, if you're looking forward to your day, whether that's your job that you get paid for, or whether that's something you're doing for yourself, your personal development, gym, eating healthy, or going out with your for a walk with your wife, or spending a bit of time with your kids, everything you got to do is part of your life. So so you balance it. So you think about doing the job you like, you enjoy, and that becomes part of your life, and then it becomes a lot easier to do all the other things in your life because we do spend a lot of our working lives, a lot of the time at work, and it's really important that it's something you enjoy. So, so what I tend to do is I tend to have a couple of really heavy days, uh, and then the other days I tend to kind of work shorter hours. But I do work across 7 days. That might not work for everybody. A lot of my colleagues will be absolutely weekend is completely free for family and other activities. Uh, in my life, with this way, it means I can spend more time with my wife and kids and my mum and other people. Because I have several roles, I kind of split the time across 7 days, and then only take on roles I enjoy. And we're all in a privileged position, and I am certainly in a privileged position to say, if I'm not no longer enjoying a role, I can change it. So work-life balance. Just think of your so because work-life balance means you enjoy your life and not your work. You got to enjoy your work, and that's part of your life.
Yeah, many people think of it as two conflicting actual activities, whereas we spend the best years of our life working.
Yeah.
Might as well enjoy what we're doing. And looking back at your career, what one thing you wish you knew earlier that would have actually saved you a lot of time and hassle?
That's a really good question. I wish. So what I didn't do was, initially, I was just applying for anything and everything in terms of career development opportunities. This is what I meant by I thought I should do this diploma, I should do that diploma, and it would have been great to have a mentor at an early stage. So the first few years I have had to kind of navigate for myself, and I think find yourself a mentor. It doesn't have to be someone who's gonna. A mentor is not somebody who's gonna know anything and everything. It doesn't have to be somebody who's a medical leader who knows who's doing different things. Somebody who kind of tells you, okay, Selva, take a step back. Why are you doing this? Um, why are you doing a DRCOG in East London where ethnic minority patients, females, are never going to come and see you, and you're going to end up doing one vaginal exam every 6 months. So what's the point of view actually trying to look, specialize in locks? Or could you think about working in a sexual health clinic, or could you think about working in a family planning clinic where there's much more opportunities? So just having a bit of guidance, I think, early on, and there weren't that many mentorship schemes available back then. So I think I would have picked one thing I wish I'd known is find a mentor early on is something I didn't have.
Yeah, that resonates with what you've said before, where now you're playing the role of mentoring others and helping them shortcut that. So it's been really good to speak with you. One last piece of advice to a GB trainee who's an IMG, who's actually moved his or her life half the world to come here and might feel a little bit discouraged at this point.
I would say to them what I say to everybody is you're not starting off in the same level playing field, right? As a UK graduate has grown up in this country, has learned medicine in this country, knows the NHS better and everything else. So you're not starting off the same level playing field, but this is not you are no less hardworking, you're no less motivated, you're no less academic and intelligent than anyone else. Because nowhere in the world is it easy to get into medicine. You've got to be in the top of your class anywhere in the world to become a doctor. So don't forget that. But you would need a leg up. So if you took me and put me in India somewhere in India where I don't speak Hindi, I'll struggle. Um, even though I've been a doctor for more than 20 years. So it's about accepting you're not going to be at a level playing field and look at help that's available to you and work a little bit harder, but don't be discouraged. Connect, be curious, and doors will open for you.
So I think it's really good to hear about these golden nuggets. And it's been so good to speak with you. Where can people find more about your work?
So I'm quite active on social media. So LinkedIn. I used to be active on Twitter, but not so much. So LinkedIn is probably where you can reach me. You can send me a DM. I'm more than happy to respond to you and have a chat offline. And a lot of people have reached out that way. And I'd already say LinkedIn is probably a platform I would look at quite regularly nowadays.
Great. So yeah, we'll put the link down in the description. And if you enjoyed this video, you might want to watch this interview I did and you get more out of how to build your career in this one. Take care, everybody. Bye-bye.